Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this today's particular very important video session, we are going to discuss the very important questions concept for our upcoming exam. So, my point is very clear here to give the quality content with the standard guidelines and the recent updates. So, I want every one of you to enjoy the session with the pen and paper and take a note of the point what I'm explaining to every one of you, and wherever I'm telling it is important, so please mention the special focus on that particular point. Okay, so because it is important and it will strike in your exam, right? So I will give the high quality content from my side, and your work is to work on that one and mold that particular content according to yourself. Okay, keep in your mind, retain it in the exam and give the best shot in the exam to get the better rank in the mains exams, right? So yes, if you are following my channel, definitely you people will clear the prelims. Okay, so if any one of you are new to the particular Master Nursing classes YouTube channel, so please do subscribe to the channel. And if any one of you are very good evening to every one of you. Yes, if you are new to our channel, so please do subscribe to the channel, right? So if you are following my channel, you will definitely clear the prelims exam and the mains exam with a very good rank. Okay, so I want every one of you to get the best rank in the exam, so you can join to your dream aims in the first single attempt only. Okay, so don't be in the mindset that like if one job is getting means that is enough, right? So after getting the job, there is lots of the things you have to face. Okay, if the job you are getting which is near to your hometown means that is the best. So to get the job which is near to your hometown, so you have to work hard and you have to get the best rank. So the first option should be and first name should be yours in the selection list, right? So work hard. This is the time to be a very confident with a very clear mindset, right? Yes, I repeatedly used to tell, don't be in the negative mindset, sir, I am getting the only 50 marks, 52 marks, 55 marks. But if you are getting the 50 to 55 marks in our test series, definitely you will get a 60 to 65 marks in the prelims exam and more than 120 marks in the mains exam. So that is more than enough to get your best rank and the selection list, right? So hope every one of you are doing your well, and very good evening to every one of you. So many of you have already joined to the session. So let me begin the session without wasting the time, right? So here is the beautiful motivational quote and powerful motivational quote to every one of you. Students, that days that breaks you are the days that makes you. Yes, if some psychological stress which is breaking you now, some pressure, the exam pressure which is breaking you now, definitely believe me, this stressful days and this particular days with a high pressure are the ever time and evergreen memory after getting the selection. Okay, so that is the thing I usually keep on repeating. Students, your destination is not that much perfect, but your journey of the destination is always enjoyable, right? So this is the evergreen memory to every one of you, right? So enjoy your preparation and give the best shot in the preparation, so that no any regression should be from our side after getting the rank. Okay, so yes, you have to say yourself, I have given my best, I have given my complete time. Okay, I am very clear with my mindset to get clear of the exam. Yes, you have to accept the result whatever it will come, but you have to very clear from your side. Just you have don't regret after the exam, sir, if I have did like this, if I have did like that. So don't keep anything in your mind, right? So keep on preparing with the quality content. Definitely result will be your side, right? So with this motivational quote, I'm here to share some information related to the Super 60 test series. If any one of you have not joined the test series, I have given the app link in the description box, in the comment box. You can join from there, okay, and get the Super 60 test series for the Norcet 9. Here in this particular test series, you are getting the mains paper also free of cost after getting the prelims exam. Okay, so if anyone of you are new, please do Super 60 test series. Link of the app of the Master Nursing classing I have given in the description box. Okay, so here's the first question in front of you all. So let's begin the real game of the discussion here, right? So the question is in front of you all. So please do read the question completely till the end and give the best answer in the comment box. Yes, I'm waiting for your response in the comment box, beta. The question is very simple. Which of the following is the best to define the preterm labor? It's a very simple question and your answer should be very clear here. Okay. So option A, onset of the labor between the 47 weeks to the 41 week of the gestation. So this is the time where it's in the term labor. We can say it is not preterm, it is not postterm. Okay. So this is the term labor, right? So then comes to the option B. So the onset of the labor after the 42 week of the gestation. Beta, if the labor is getting onset, okay, so the true labor pain have started after the 42 week of the gestation, means I call this one is in the post term labor, right? But in the question what they have asked, so they have asked related to the preterm labor. Okay, so the option C, onset of the labor between the 20 and before the 37 completed weeks. Okay, so here between the 20 weeks to the before the 37 week, means at the term, means after the 37 is the term, before the 37 if the like labor process is beginning, we call that one as the preterm. Okay, so that is very very important. Before the 20 week or the before the period of the viability, we call that one as the abortion, right? So after the 20 week and before the 27 week, sorry, before the 37 week, we call that one as the preterm labor. Okay, so option C goes to the correct answer here, and many of you have chosen the correct answer. That is the preterm labor is the onset of the labor between the 20 weeks and the before 37 week of the period of the gestation. So this will be our correct answer, right? Then comes to the option D. So onset of the labor at the term with the premature rupture of the membrane. Better. So here this onset of the labor is happening at the term. So this is not preterm labor. Okay. So I'm eliminating the option D also here. Okay. So I hope everybody's like basic is very clear, right? So this is just to clear your basic related to the postterm labor, term labor, preterm labor. If it is happening after the 37 week of the gestation and before the 31 week of the gestation, that is the term labor. If it is happening after 42 week of the period of the gestation, that is the postterm labor. If it is happening before the 37 week of the gestation, that is the preterm labor. Okay, hope it is clear to every one of you. It is very basic. Sometime the question will comes to here. Okay, so whatever thing I have explained, more than 42 weeks, that is the post term, right? So less than 37 week, that is the preterm. Okay, so 37 week to till 41 week plus 6 days, we can say this is the term. Okay, so remember the very very important definitions and the criteria to diagnose the preterm, postterm and the term labors. Okay, so here is the next question. So please do read the question. It is already many times discussed questions. Okay, and it is very basic question and the very very important question, right? Yes, do read the question and give the best answer in the comment box. Which type of the pneumocytes are responsible for the production of the surfactant in the lungs? Okay, so option A is the type 1 pneumocyte, option B is the type 2 pneumocyte, and option C is the alveolar macrophage, and option D is the goblet cell. So what is the correct answer? Which type of the pneumocytes are responsible for the production of the surfactant in the lungs? Okay, so this particular word surfactant, okay, so this is the fluid which is present in the lungs, which is responsible for to maintain the surface tension of the lungs. Okay, it will maintain the surface tension of lung and which not allows the lungs to get collapse. Okay, so it will not allows the lungs to get collapse. If surfactant is normal, means yes, the lungs will not get collapse. If the surfactant is deficient, means there is a chance of the collapse of the lungs, and in the newborns there is highest chance of the respiratory distress syndrome. Okay, so the question will become in your exam, yes, due to the which deficiency the RDSM happens in the preterm. Okay, so especially which happens in the preterm. Okay, if the baby is getting born before the for 37 week of the gestation, so lungs are completely immature because the surfactant have been not produced perfectly. Okay, so that is the reason. Okay, in the preterm labor there is highest chance of the respiratory distress syndrome. Okay, so there is highest chance of the respiratory distress syndrome. Very, very important. Just try to keep in your mind because it is important. Okay. So the first question is very clear here. Which type of the pneumocyte is responsible for the production of the surfactant? And many of you have given the correct answer. So that is the type 2 pneumocyte is very much important and responsible for the production of the our surfactant fluid in the lungs of the fetus. Okay. So do remember the golden word, that is the type 1 alveolar cell we can say, or we can say the pneumocytes. Okay. Pneumo means air here, cyte means cells here. Okay. So that is the type 1 pneumocytes or the type 1 alveolar cell is the, so that is responsible for the gas exchange. Okay. This is responsible for the gas exchange at the lungs. Okay. Very, very important. And the type 2 pneumocytes, which is responsible for the, yes, production of the surfactant. Very, very important in the newborns, which is responsible for the production of the surfactant fluid. Okay. So then the type 3 pneumocytes, very, very important. Again, type 3 pneumocytes, which is responsible for the maintaining the defense, maintaining the immunity at the lungs. Okay. So that is what we call as the alveolar macrophage. Okay. So it will act as a defense cell or the immune cell. So that is the alveolar macrophage. Very, very important. Just keep in your mind the golden points. Okay. So then in the option D we have one cell that is called as the goblet cell. So this goblet cell, which is responsible for the production of the mucus and production of the secretions in the respiratory tract. Okay. So which cell will get produces the mucus and secretion in the respiratory cell? Okay. So this is the mucus producing cells at respiratory system. Okay. So very, very important. Just try to keep in your mind the goblet cell is the cell which is responsible for the production of the mucus and the alveolar macrophages. We also call this one as in the type 3 pneumocyte, which is responsible for the maintaining the immunity at the alveoli, and type 2 is responsible for the production of the surfactant. As our point of the question is option B goes to the correct answer. Then the type 1 pneumocyte is responsible for the very, very important gas exchange, means whatever the oxygen we will inhale, it will be gone to the blood, and whatever the carbon dioxide will comes from the blood, it will go to the our lungs and it will get exhaled by the lungs, because the gas exchange which happens between the blood vessels and the type 1 pneumocytes. Okay. Or we can say the type 1 alveolar cells. Okay. Very, very important. Just try to keep in your mind the golden points, right? So here is the next question. So please do read the question completely and carefully and perfectly. So then try to give the best answer in your comment box, because it is very, very important question, and this question have been asked many times in your exam. Okay. So all the tests I will discuss very quickly, and the golden points related to the particular test I will tell to you. Okay. So please take a note of the thing, because it is a very, very important question. Okay. It is in the very important question. The concept you are understanding means no one can stop you to get select in the exam. Okay. So which of the following is the most commonly used test to assess the fetal lung maturity? Better, there are the two words you have to focus when in the questions while answering the test of the fetal lung maturity. One is the most common test, means the answer goes to the yes. Which one is the answer? So fatapat do comment in the comment box. So what is the answer? Most common test used for the assessing the fetal lung maturity. So most common test is always and always less than sphygmomyelin ratio. So this will be a most common test performed. Okay. So the best test, if the examiner is asking the best test to or the best indicator for the fetal lung maturity, is the phosphatidylglycerin is the always best test. Less than sphygmomyelin is the always most common test. Okay. So very, very important. Just try to keep in your mind, right? So Nile blue test and the bubble test are the test. So we can perform this test at the bedside. Okay. So we can perform this test as the bedside by collecting the sample and so viewing the particular fluid. Okay. So I will explain how we have to perform the Nile blue sulfate test, how we have to perform the bubble test, how to interpret that one, and what is the phosphatidylglycerol test, and what is the lecithin to sphygmomyelin ratio here. Okay. So I hope the thing is clear, the question is clear here. The which is the most common test means, so that is the lecithin to sphygmomyelin is the most common test what we have to perform here. Okay. So let me discuss the lecithin to sphygmomyelin. Okay. So if the lecithin to sphygmomyelin in the amniotic fluid, okay, if it is more than 2, so that we can say which is the a fetal lung is mature. Okay, so or the ratio we can say if it is 2:1, so we can say that that is the a fetal lung is matured. Okay, fetal lung is matured, right? If in case the lectin is to sphygmomyelin ratio, if it is less than 2, so we can say fetal lungs are immature. Okay, so the fetal lungs are immature, right? So what is the lectin versus the sphygmomyelin? These both are the phospholipid which are present in the amniotic fluid. Okay, which are present in the amniotic fluid. Okay, so we can do the amniocentesis and take the amniotic fluid sample. In the amniotic fluid, we will assess the ratio of the sphygmomyelin and lectin. If the ratio is less than 2, that is the fetal lungs are mature. Sorry, if it is the ratio is more than 2, the fetal lungs are mature. If the ratio is less than 2, yes, the fetal lungs are immature. Okay, it is very basic and very important. Just try to remember. Okay, so the next test what we have here is the phosphatidylglycerol. Okay, so if the examiner is asking the best test, okay, overall is also or best test in diabetic mother to check fetal lung maturity in the diabetic mother to check the fetal lung maturity. So that is the always and always the phosphatidylglycerol. Okay, so that is the always and always very important. Remember the word phosphatidylglycerol. Okay, so if the phosphatidylglycerol, this phospholipid, if this one is present, means we can say fetal lungs are mature. And if the phosphatidylglycerol lipid is absent, we can say that is the fetal lungs are immature. Right, so very important thing, just you have to keep in your mind. So this is the always best test overall, and this is the always best test to assess the fetal lung maturity in the diabetic mother also. Okay, so this is the very important, just try to keep in your mind. Okay, so then comes to the point, so that is the Nile blue sulfate test. Okay, so this Nile blue sulfate test, what we will do, okay, so here we will take the amniotic fluid, and in the amniotic fluid there is a protein, so that is the phospholipids is there and the protein is there, and the surfactant phospholipid and the amniotic phospholipid is almost same. If in the amniotic fluid we have the phospholipid, means it means in the like in the surfactant fluid also we have the phospholipid, means the phospholipid is present, that means the amniotic fluid is in the amniotic fluid phospholipid is present, means in the lungs the surfactant fluid is present. Okay, so why? Because the surfactant fluid is also made up of the phospholipid. In the amniotic fluid we have the phospholipid, so that is in the fetal skin cells we can take. Okay, so in the skin cells we have the phospholipid, means the phospholipid is present. It means in the amniotic fluid, in the fetal lungs we have the surfactant fluid, so in the surfactant fluid also made up of the phospholipid, so here also phospholipid present, means in the fetal lung also phospholipid present. Phospholipid present means surfactant present. Surfactant is present, means that means very importantly the lung is matured. Okay, so here we will do one test, that is what we call the Nile blue sulfate test. So here we will take, what we will take here means we will take the amniotic fluid sample. Okay, so in the amniotic fluid we will specially focus on the fetal skin. Okay, so fetal skin cells or the any cells we can take. Okay, so here in this one we will add the Nile blue sulfate. Okay, what we will add here? We will add here the Nile blue sulfate. We will add here. If we are adding the Nile blue sulfate test, so after adding more than 50% of cells looking orange color. Okay, looking orange color. So that means yes, the more than 50% cells are looking orange color, means it means there is in the phospholipid is present. Phospholipid is present in the fetal skin, means yes, the phospholipid present in the lungs of the fetus also. phospholipid present in the lungs of the fetus means the surfactant present in the lungs of the fetus. Okay, the surfactant is present in the lungs of the fetus means fetal lungs are mature. Means if we are getting the more than 50% of the cells which is looking like orange color means we say this one is in the fetal lung is mature. Okay, we can say this one is in the fetal lungs are mature. Okay, if in case less than 50% of the cells are looking like orange means so there is no any cells which is looking like orange means so that is the fetal lungs are immature. So very important, just try to keep in our mind because it is important, right? The next one is what we have is the bubble test. Okay, so what we will do in the bubble test? Yes, so this is also a bedside test we can do here. Okay, so in the bedside test, what we will do in the bubble test? These are the important thing. Just I am superficially rapidly revising for you all. Okay, so in the bubble test, what we will do? Okay, we will take a test tube. We will take a test tube. In the test tube, we will add the amniotic fluid. Okay, we will add the amniotic fluid. So in the amniotic fluid, you know the surfactant fluid is present. Okay, so if the surfactant fluid is present, so when you will shake this one, okay, so when you will shake this one, shake the particular test tube. Okay, if the foam is present or if the bubbles are present, so that means inside the amniotic fluid the surfactant fluid is present. Okay, so surfactant fluid is present means that is the fetal lungs are mature, right? So if the bubbles are absent, so the amniotic fluid is in the amniotic fluid there is no surfactant fluid. Okay, so the no surfactant fluid means the fetal lungs are immature. Okay, so hope all the four tests are very clear here and rapidly we have revised the four tests. Bubble test. In the bubble test, what happens? Bedside we will take amniotic fluid. We will insert. We will add the test tube. Okay, in the test tube we will add the amniotic fluid and we will shake the test tube. If the foam and bubble is present, so there is the insert the amniotic fluid. The surfactant is present. That is what you call as in the very important. Fetal lungs are mature. Okay, so after shaking the test tube, there is no any bubbles, there is no any foam means inside the amniotic fluid there is no any surfactant. No surfactant means that is the fetal lungs are immature. Okay, so the second one is the Nile blue sulfate test. In the Nile blue sulfate test we will add amniotic fluid or in the amniotic fluid we will look for the fetal skin cells. Okay, so in that one we will add the Nile blue sulfate and if the more than 50% of the cells in the microscope which is looking like orange color, the fetal lungs are mature. If the less than 50% of these cells or that there is no any cells which is looking like orange color means the fetal lungs are immature. Very simple, right? So the next one is the best overall test, that is the phosphatidylglycerol. Okay, in the fetal lung, phosphatidylglycerol is present in the amniotic fluid means that is the fetal lungs are mature. In the amniotic fluid, the phosphatidylglycerol is absent means that is the very important fetal lungs are immature. Right? So this is the overall best test and the best test in the diabetic mother to check the fetal lung maturity. The best test is the always the phosphatidylglycerol and the most common test, that is the less than is to sphygmomyelin. If it is more than 2 or the more than 2:1 ratio, fetal lungs are mature. If it is less than 2, the fetal lungs are immature. Okay, so all the four important tests of the amniotic fluid and the fetal lung maturity we have discussed here. Okay, so the next question is here in front of you all. So please do read the question completely, carefully, and try to give the best answer in the comment box. Yes, which corticosteroid is best used to enhance fetal lung maturity in case of the threatened preterm labor? Okay, so there is in the threatened preterm labor is there, or we can say there is in the preterm labor. Okay, so preterm labor means the labor which is starting less than 34 week of the gestation, and in this particular situation I told there is highest chance of two problems. Okay, one is immature lung, and another one is the immature or underdeveloped brain. Okay, so in order to promote the lung maturity we have to give the a very important drug, so that is called as the corticosteroids. Okay, corticosteroids are the drugs what we have to give in the preterm labor to promote the fetal lung maturity. Okay, and in order to promote the brain maturity, we have to give the central vasodilator, that is the MgSO4, or we can say the magnesium sulfate. So this will be a central vasodilator, so it will increases the blood supply to the brain of the fetus, and brain will get matures here. Okay, so very important. The two very important problem what we will face in the preterm labor is the immature lung and the immature brain. To promote the immature lung to get mature, so we will give the corticosteroid, and we have to give the MgSO4 to promote the maturity of the brain. Okay, so very important. Hope you understood the concept here. And the question is, which corticosteroid is best here? Okay, so I told, so corticosteroids are the drug of choice, and which corticosteroid among this one is the best one? Okay, so the best one used to enhance the fetal lung maturity in case of the preterm labor is, so beta, previously in India the most commonly used was the dexamethasone, because this was available in a cheap rate. Okay, so it will be a 30 rupees, means the betamethasone will be a 700 rupees. Okay, so there is a lots of the differences there between the rate of the dexamethasone and betamethasone. So that is the reason previously in India the used one is the dexamethasone, but now the Indian people are rich, the Indian people are well educated, and the Indian people is looking for the quality healthcare. So the best and the most commonly used drug in a preterm labor is the our always and always betamethasone goes to the correct answer. Okay, so remember this one. Right, so always and always, which one is goes to the correct answer? That is the betamethasone goes to the correct answer. Remember. Okay, sir, even if you are giving the option in the of the dexamethasone, you have to choose the betamethasone as the correct answer. Okay, so this is very important. Just try to keep in your mind. Right, sir, how we have to administer this betamethasone? Yes, whether we have to give this one is in subcutaneous, intradermal, or the IV or the IM, which route we have to administer the betamethasone? Yes, the route of administration of the corticosteroids to promote the fetal lung is the intramuscular. To whom we need to administer, sir? To the fetus or to the mother? Beta, how we have to administer to the fetus? It is not possible to administer the fetus, so to mother only we will give. Okay, so to mother only we will give. So through the mother it will go to the fetus. Okay, so it will get the lung maturity in the fetus. Right, so very important. Just try to keep in our mind. Once after administration, it requires at least 48 hours to get act on the fetal lungs. So that is the reason whenever you will administer the like corticosteroids, so try to push the or try to continue the labor for the next 48 hours. Okay, so how we have to continue the labor means, so we have to reduce the uterine contraction. So in order to reduce the uterine contraction, we have to give the another drugs along with the corticosteroid, that is what we call the tocolytics. Okay, tocolytics means, toco means contraction, lytics means breaking. So breaking the contraction means here it means the reducing the contraction of the uterus. So that is the tocolytics are the drugs we are using to reduce the uterine contraction. Okay, so very important one. Try to keep in our mind. Right, so I told after administration of the corticosteroid, it requires at least 48 hours to get act. Okay, so we need to promote the labor till at least 48 hours. Okay, so that is the reason we will give the corticosteroid here. So what is the regimen of the administration of the corticosteroid to promote the fetal lung maturity, sir? So this is the regimen, beta. Remember. Okay, so corticosteroid for fetal lung maturity. Okay, so previously in India we used to use the a drug called as in the dexamethasone. Okay, so in India previously we used to use the drug called as the dexamethasone. Now we are using the betamethasone in India also. But so remember the dose of the dexamethasone, because it is important to know the regimen. Okay, dexamethasone. Okay, so this one will be given in the 4 doses. Okay, so the total dose will be the 4 doses. So how to give the 4 doses? Yes, first you have to give the 6 mg, then maintain the gap of the 12 hours. Okay, so then give the next 6 mg, then the gap of the 12 hours, then the next 6 mg, then the gap of the 12 hours, then last 6 mg. Okay, so this is the very important, how much gap you have to have in each dose. Okay, so total is the 4 dose with the 12 hours gap we have to give. Okay, so this is the very important. Then comes to the recently and the best drug what we are using, that is on the betamethasone. So this one, how we have to administer, sir? Betamethasone total dose is the 2 dose. Okay, sir, how to give this one? Yes, first dose, that is the 12 mg with 24 hours gap. Then the next dose will be the 12 mg. Okay, so total how much mg we are giving? So again, we are giving the 24 mg, and here also we are giving the dexamethasone also 24 mg, but it is divided into 4 dose. Okay, so 4 dose, that is the 6 mg, 6 mg, 6 mg, 6 mg with 12 hours gap, right? So in the betamethasone, we are giving the 2 dose. Okay, so that is the 12 mg, 24 hours gap, and again the 12 mg. Okay, so very important, the corticosteroids for the fetal lung maturity is like this, which is mentioned in the exam. Okay, which is mentioned in the particular chart. Okay, so this is the very important chart for every one of you, right? So the next question is here in front of you all, so please do read the question carefully, completely, then try to give the best answer in your comment box. Okay, so option is in front of you all and question is in front of you all, so please do read the question and give the best answer in the comment box. Yes, the question is very simple. Fetal fibronectin is normally absent in the cervicovaginal secretion during which gestational age range? Yes, beta. This fibronectin protein is a very important protein which we will use to diagnose the risk of the preterm labor. If the fibronectin is present in between the 22 to 36 week of the gestation, we can say that is there is highest chance and risk of the preterm labor. Okay, so the question will come, which protein we will use to predict the risk of the preterm labor, or the which biochemical marker we will use to predict the risk of the preterm labor. So always give the best response, that is the fibronectin is the biochemical marker, so which we are using to predict the risk of the preterm labor. Okay, so this particular fibronectin protein normally which is present before the 24 week. Okay, so normally which is present before the 22 week. Okay, and it is also normally present after the 37 week, but it is normally it should absent between the 22 week to the 36 week of the gestation. Okay, so here the preterm labor will happens in this particular period, which is normally absent between the 22 weeks to the 36 week of the gestation. If it is present, means there is highest risk of the preterm labor. Okay, so very important, just keep in your mind. Sir, how we have to diagnose the preterm labor, sir? So there is then the diagnostic criteria, remember beta. So diagnosis of the preterm labor, so how to diagnose means first and priority, so there will be a uterine contraction before 37 week. Okay, so uterine contraction started before the 37 week. Along with this one, okay, so there will be any one of the following. Okay, so along with this one, any one of the following. So which one is that one? So that is the USG criteria, or there is the fibronectin presence. Okay, so first one is in the USG. Okay, so normally in the pregnancy the length of the cervix will be 4 centimeter. Okay, so normally length of the cervix in the pregnancy will be 4 centimeter. If the length of the cervix in the pregnancy, if it is less than 2.5 centimeter length, and the cervix which is dilated more than 2 centimeter, this is the cervix. Okay, so if the length of the cervix is less than 2.5 centimeter and the dilation of the cervix which is more than 2 centimeter, so there is highest chance of the highest chance of preterm labor is there. Okay, so this is the USG diagnostic criteria of the preterm labor. Another one is, I told, usually in between the 22 weeks to the 37 week of the gestation, this fibronectin protein should be absent. If if this fibronectin protein is present, it means it is having the highest risk of preterm labor. Remember, very very important, right? So fibronectin, it is present normally before the 22 weeks. It is present normally after the 37 week, but it should absent between the 22 week to the 36 week. If it is present between the 22 week to the 36 week, it indicates the highest risk of the preterm labor. This is the basic concept, just you have to keep in your mind, right? So hope it is clear, and the diagnostic criteria is clear to everyone of you. Okay, so uterine contraction, if it is happening less than 37 week, along with any USG criteria or the fibronectin. Okay, so if the fibronectin present means yes, that may be a chance of the preterm labor, or the in the USG the length of the cervix is less than 2.5 centimeter and the dilation of the cervix is more than 2 centimeter, so there will be highest risk of the preterm labor. Okay, so in the preterm labor, so due to the decreased length and increased dilation, so cervix looks like this. Okay, so this is the length of the cervix only less than 2.5 centimeter and the dilation of the cervix is more than 2 centimeter, so the cervix looks like U shape. Okay, so the question have been asked in the preterm labor how the cervix looks like, so that will be a U shaped cervix. Okay, so U shaped cervix we will get in the case of the preterm labor. Okay, so remember, very very important one. Okay, so here is the next question which is there in front of you all, so please do read the question carefully, and the comment box is open for every one of you, so please do mention your answer in the comment box. Okay, so what is the primary reason of the magnesium sulfate is administered to a woman at risk of the imminent preterm birth before the 34 week of the gestation? So very very important point, already I have discussed. In the preterm labor there are the two very important dangerous situations are there. One is there is in the immature lung. To promote the maturity of the lung, we are giving the corticosteroid. So best one is the betamethasone. Okay, so I have explained the regimen also. That is the two dose of the betamethasone, 12 mg, 12 mg, 24 hours gap, and the previously most commonly used one is the dexamethasone. That is the 4 dose, 6 mg, 6 mg, 6 mg, 6 mg with the 12 hours gap. Okay, so this was the regimen I have explained, right? So now in this question they are asking why we have to give the magnesium sulfate. Okay, so another situation I have explained along with this one. So there is on the immaturity of the brain is there. To promote the maturity of the brain, we have to give the central vasodilator, so that will increase the blood vessels size in the brain, and it will promote the high oxygenated blood continuously to the brain, and there will be a chance of the brain maturity will be increased. Okay, so in this particular situation we have to give the central vasodilator, that is the magnesium sulfate. Okay, so in the question what they are asking, so what is the primary reason of administering the MgSO4 in the preterm labor? Okay, so the question is very simple. What is the primary reason of the MgSO4 or the magnesium sulfate is administered to a woman at the risk of the imminent preterm birth? Okay, so before the 37 week of the gestation, remember. So the answer should be the yes. So for to mention your answer. Option A, to promote the fetal lung maturity. Better to promote the fetal lung maturity, what we are given? We are given the corticosteroids. Okay, how we have given? We have given by the intramuscular route. To whom we have given? We have given this one to the mother. Okay, so already we have discussed this particular points already, right? So then comes to the option B, right? So in the option B, to stop the uterine contraction and to continue to stop the uterine contraction permanently. So this is not a work of the MgSO4. This is the work of the Tocolytics drugs. Okay, so this is the work of the Tocolytic drugs. Okay, so then comes to the option C, to brain maturity. So to promote the brain maturity, so we can give the MgSO4 in the preterm labor. Okay, so remember better. So this regimen and this particular very important drugs what we have to administer in the pregnancy. Okay, so make a table like this. Okay, so here we'll write the drug name and the when to give and why we are giving. Okay, so why to give, just for your simple remembering purpose, the first drug we are giving is the corticosteroid. Okay, so when to give? If the preterm labor which is happening less than 37 week of the gestation, we have to give this one. So why we have to give? To promote fetal lung maturity. Okay, so this is the a very important thing just to remember here. Okay, so the next one is which drug we are giving? We are giving the tocolytics. In the preterm pregnancy, we are giving the tocolytics. So why we have to give the tocolytics? Tocolytics should be given to promote the or to continue the labor for the next 48 weeks or 48 hours. Why? Because I told that corticosteroids require at least 48 hours to get action. Okay, so till that we have to promote the labor or we have to postpone the labor for the next 48 hours. Okay, so when to give this one? If the labor onset is happening less than 34 weeks, then only give the tocolytics. If the labor is onset is happening at the 35 weeks, 36 weeks, 37 weeks, so don't give the tocolytics, because so if the 34 week have been crossed means the fetal lungs are already matured. Okay, so remember the tocolytics should be given if the preterm labor is happening less than 34 weeks only. If there is the fetus which crossed the 34 weeks, so there is no any role of the tocolytics. Okay, so the tocolytics are the drugs which we are giving to reduce the uterine contraction, and it is given only for the short duration and it is given only for the temporary management. Okay, so to promote the or to postpone the labor for the next 48 hours after administering the corticosteroid, because the corticosteroid are require at least 48 hours to get onset of its action. Okay, so that is the reason. So we are giving the tocolytics. So when to give the tocolytics? The tocolytics should be given if the onset of the labor which is happening before 3-4 weeks or before the 34 weeks. Okay, remember very important point. So why we are giving this one? To decrease uterine contraction temporarily. Okay, so temporarily, right? So remember the next drug what we are giving here, so that is the very important drug. So the drug name is, yes, that is the MgSO4, that is the magnesium sulfate. So this one will be given same in the before 34 week. If the labor onset which is happening before the 34 week, then only give the MgSO4. Why? Because if the labor which have been crossed the more than 34 week means the brain have been already matured. Okay, so there is no any requirement of the MgSO4. Okay, if the preterm labor happening before the 34 week, give the MgSO4. Which is happening after the 34 week, don't give the MgSO4. Okay, so why we are giving the MgSO4 in the preterm labor? Yes, to promote fetus brain growth. Okay, so to promote the fetus brain growth. So this particular chart is very important to every one of you. It will be directly struck in your exam. So what are the points? So when to give this one MgSO4? Before 34 weeks. When to give the tocolytics? Before 34 weeks only. So corticosteroid we can give till the 37 week. Okay, so but the tocolytics and MgSO4 should be given before 34 week only. Okay, so why corticosteroid? Fetal lung maturity. Why the tocolytics? Reduce the uterine contraction. Why the MgSO4? Promote the fetal brain growth. Okay, so very important. Just try to keep in our mind because it is the important concept, right? Yes, the next question is here. Which of the following medication is commonly used as a tocolytic in a delay preterm labor in the diabetic mother? So to delay the preterm labor or to postpone the preterm labor in the diabetic mother, which of the following is medication which we can use commonly here? Okay, so yes, the most common used, the best medication is always the calcium channel blocker. Okay, so which is having the ability to reduce the uterine contraction with a very less side effect. So that is the reason always most commonly used and the best one in the overall also the nifedipine, and in the diabetic mother also the nifedipine. Okay, so very important, keep in your mind, right? If we are giving the oxytocin which increases the uterine contraction and it is again increases the risk of the preterm labor. So oxytocin is contraindicated in the preterm labor. Okay, so we will give the drug which will act opposite to the oxytocin. Okay, so that is we can give here as in the atosiban. Okay, so this atosiban is the drug which will works as in the oxytocin antagonist. Okay, so we can give this also atosiban in a preterm labor. Okay, so this is the best drug. Atosiban is the best drug with the best tocolytics in the heart disease patient. Okay, so in the heart disease patient we can't give the calcium channel blocker, because the calcium channel blocker, you know, it will do the vasodilation and it will causes the hypertension. Okay, so that is the reason in the nifedipine is the not best in the heart disease. Okay, so if someone is asking best tocolytics in the heart disease patient, that is the atosiban. Okay, so that is your atosiban, very very important, right? So the misoprostol and methyl dopa is not having any role in the promoting the preterm labor. Okay, so very very important, keep in your mind the best is always and always that is our nifedipine, the calcium channel blocker. Okay, so hope it is clear to every one of you, right? Here is the next question. Okay, the question is very simple. Which of the following are teratogenic effect of the most common teratogenic effect which is most commonly associated with the antenatal exposure to the endomethacin? Beta, so this endomethacin is also in the tocolytic. Okay, so this endomethacin is also in the tocolytic, which we can use to promote or which like postpone the labor. But this endomethacin is in the non-steroidal anti-inflammatory drug. Okay, so we can say this one is in the COX inhibitor also. Okay, so we can say this one is the COX inhibitor. So COX is inhibiting means there is decrease in the prostaglandin. Okay, so prostaglandin is decreased means this prostaglandin is very important for the maintaining the ductus arteriosus patent, means so there is in the a connection between the descending aorta of the heart, okay, and the pulmonary artery of the heart. Okay, so there is a connection between the descending aorta and pulmonary artery of the heart. So this is what you call as in the ductus arteriosus. Okay, so the pulmonary aorta descending artery. Okay, so the connection between the artery is the ductus arteriosus. Okay, so to maintain the patency of this ductus arteriosus, prostaglandin is very important. This particular prostaglandin is very important. Here we are giving the endomethacin, means it is the COX inhibitor. So this COX inhibitor is decreasing the prostaglandin. So decreasing the prostaglandin means this particular ductus arteriosus become closest prematurely. Okay, so the most common and the most commonly associated what we can say the like teratogenic effect of the endomethacin is the premature closure of the fetal ductus arteriosus. So this may be your direct question, it may strike in your exam. Okay, so do remember this question, it is very important. Okay, so endomethacin is also having the ability to cause the oligohydramnios. Okay, it will also cause the oligohydramnios. Remember the two side effect of the endomethacin in the pregnancy. One is the oligohydramnios, another one is the premature closure of the fetal ductus arteriosus. So that is the reason. Okay, if someone have asking the question which tocolytic drug which is having the highest fetal side effect, so that is the endomethacin. Okay, so remember, right? So here are some golden points chanting for you all. Okay, so tocolytic which we are using to delay the preterm labor by reducing the contraction. Okay, so here the best tocolytics in the heart disease mother is the always our atosiban. This is in the oxytocin antagonist, means it will works against the oxytocin. So oxytocin is responsible for the uterine contraction. So this atosiban is working against the oxytocin, means the oxytocin will not act, and the oxytocin is not acting means the uterus will not contract. So uterus is not contracting means the labor will get postponed. Okay, so best drug in a heart disease mother is the atosiban, right? The next one is the tocolytic we can use with maximum fetal side effect is the, yes, just now we have discussed. Just give me a second, please. Right. So just now we have discussed a tocolytic used with the maximum fatal side effect is our, that is our Indomethacin. Okay, so that is our indomethacin. So already we have discussed this one, right? So sorry, endomethacin, maximum fatal side effect, right? So the next point of the discussion is the tocolytics used with the maximum maternal side effect. So here you have to remember the beta agonist or the tocolytics we will use. So these all beta agonists are the tocolytics where what we are using here are having the highest side effect to the mothers. Okay, so how we have to remember this one, sir? Just we have to remember by the writ this side and the writ this side. Okay, so that is the very important drugs what we have to remember here. That is the retrodrin and just give me a second. Some struck is happening here. Technical error. Please give me a second. I will correct this one. Yes. So the beta agonist, okay, the tocolytic which we are using with the maximum maternal side effect is the beta agonist. Okay, so in the beta agonist, I told to remember with the rit and rit. Okay, so this side also rit. So there is the retrodin this side and this side also rit. So this is the very important thing you have to remember as a mnemonic. And so second drug we have here is the isoxaprine. Okay, and the last one is the terbinafine. Okay. So these drugs are the drugs, okay, so you can remember with the highest maximum fatal side effect. Okay, so if someone is asking the question, so what is the most common side effect of the beta agonist? So remember the most common side of the beta agonist drugs are the tremors. Okay, and it will also having the ability to cause the hyperglycemia. Sir, how the beta agonist will cause the hyperglycemia? What is the reason, sir? How we have beta agonist will cause the hyperglycemia? Yes, beta agonist means it will stimulate the beta cells. Beta cells are stimulating means yes, there may be a chance of release of the glucagon from the pancreatic cells. The glucagon is released means it will break the glycogen from the liver and it will increases the blood glucose level. Okay, so that is the reason this beta agonist drugs. Okay, so these are always contraindicated in the patient with the hyperglycemia. Okay, so very important. Try to remember this one. Okay, so very importantly, so most common side effect of the beta agonist are the tremors and also it will cause the hyperglycemia. So that is the reason these beta agonists are not given in the pregnancy with diabetes. Okay, so tocolytics with maximum maternal side effects are the beta agonists. Okay, so the drugs are like this: retrodrin, isoxaprine, terbinafine. Okay, so here the most common side effect is the tremors and it will also cause the hyperglycemia. So beta agonists don't give in the hyperglycemia. Okay, so like tocolytic with maximum fatal side effect is the indomethacin. Why? Because it will causes the premature closures of the patent ductus arteriosus. Okay, so best tocolytics in the heart disease mother is the atosiban. It just works against the oxytocin and it will not do any side effect on the heart of the mother. Okay, so very important concept is clear to everyone of you, right? So here's the next question, right? So fatafat, do read the question completely carefully and try to give the best answer in the comment box. Yes, I'm waiting for your response in the comment box. So do the answer fatafat in the comment box. The question is very simple. A 35-week pregnant woman presents with a cervical dilation of the more than 2 centimeter. Okay, I told beta the age of the gestation is the 35 weeks. Just mark this one and remember. Okay, so the next is the cervical dilation is happening more than 2 centimeter. And what is the most appropriate next step of the management? So remember, whenever there is in the cervix which is dilated more than 2 centimeter and the length of the cervix is less than 2.5 centimeter and the uterine contraction have been started less than 37 week. Okay, so if the fibronectin protein fibronectin protein is present. So this all indicates, so this is the case of the preterm labor. Okay, so this is the case of the preterm labor. Okay, remember here the 35 week of the pregnant, she have cervical dilation more than 2 centimeters. So the labor have been onsetted, and the now she is a case of the preterm labor. So what is the most appropriate next step of the management? Option A, immediate induction of the labor. Beta, in the preterm labor we have to continue the labor till the 37 week. That is our try. So we will not induce the labor here. Okay, so I am eliminating the option A. So then comes the option B, administer the corticosteroids. Then the option C, give the MGSO4. Okay, option D, administer the tocolytics. Beta, tocolytics should be administered. I told when to administer the tocolytics. If the preterm labor which is happening less than 34 week, then only we have to administer the tocolytics. Right? So mother is here is the 35 week of the gestation. Are you able to remember this table? I told here. Yes, if the tocolytics we have to give the less than 34 weeks, MGSO for less than 34 weeks. Only thing we have to give the more like till the 37 week means that is the our corticosteroid only we can give that till the 37 week. Okay, so very important, right? So then comes to the our question here. So here a case is a 35 week, but in the option D they have given the tocolytics, so that we can give the tocolytics till the 34 week only. Okay, so this answer is not correct here. Okay, so then the option C is the MGSO4. Better, I told MGSO4 also will be given if the preterm labor which is happening for the less than 34 week, because to promote the fetal brain maturity we are giving the MGSO4, right? So that is also we will give less than 34 week only, but here the mother is having the 35 week of the gestation. Okay, so only we can, one drug we can give after the 34 week till before the 37 week is the our corticosteroid. So this particular answer goes to the correct answer, option B. Okay, so very important, remember the chart what I have explained above. Okay, so then next is here. Yes, try to understand the question, then give the correct answer. So now here is the age of the mother is the 32 week of the pregnant. Okay, so this woman, she now having the cervical dilation of the more than 2 centimeter. Okay, the cervical dilation of the woman is the more than 2 centimeter. Okay, and indicating the preterm labor, right? So what is the most appropriate next step in the management? Yes, option E, immediate cesarean section. Why we have to do the cesarean section? There is no any indication for the cesarean section here. I am eliminating the option A. Okay, so then the option B, induction of the labor. Beta, already labor have been started here because the cervix have been dilated more than 2 centimeter. So that is in the 32 week of the pregnancy only. So that is already labor have been started. So that is in the preterm labor. Okay, so patient is in the already preterm labor. Okay, so there is no any meaning of the inducing the labor. Okay, so expectant management without intervention is not like it is in the not correct intervention. So always answer goes to the administer the corticosteroid. Okay, because the labor have been begun preterm, so there is highest risk of the immature brain, there is highest risk of the immature lung. Okay, so that is the reason. So corticosteroid we have to give here to promote the fetal lung maturity, and tocolytics we have to give here to promote at least 48 hours of the labor. Okay, so we have to continue the labor for the next 48 hours. So because the corticosteroid effect may continue. Okay, so the MGSO4 we will give here to promote the brain of the fetus. Okay, so promote the maturity of the brain of the fetus. Okay, so very important, remember. So correct answer for this question goes to the our option B, administration of the corticosteroids and the tocolytics and the MGSO4. Okay, so hope it is clear to every one of you, right? So these are the very important questions what we have discussed today, and here is the next question we have here. Okay, so what is the correct answer? What is the correct answer for this particular question? So please do try to give the best answer here. Which of the following is common cause associated with the post-term pregnancy? Yes, what is the common cause which is associated with the post-term pregnancy? But I told what is the post-term pregnancy? Yes, if the pregnancy is happening more than 42 week of the gestation, so we call this one as in the post-term pregnancy. So which of the following is the common cause which is associated with the post-term pregnancy? Option A, multiple gestation. Yes, it may causes the like if in case of the twins means, so that may causes the preterm labor, not the postterm labor. Okay, so I'm eliminating the option A here. Okay, so then comes to the option B. So inaccurate estimation of the gestational age. Option C, history of the preterm labor, and option D, anencephaly. Yes, what is the correct answer? So please do mention your correct answer in the comment box. What is the most common cause of the post-term pregnancy? Beta, remember. So whenever the mother is crossing the 42 week of the gestation and still she don't have the onset of the labor, so we call this one as the post-term labor. So this may happen due to the miscalculation of the expected date of the delivery. Okay, so that is the inaccurate estimation of the gestational age or the miscalculation. Okay, miscalculation of the expected date of the delivery. So this is the most common cause. So whenever the patient will comes with a like postpartum labor symptoms, so always we have to recalculate. Always we have to recalculate the expected date of the delivery. Okay, so this will be our first point. Okay, so very important. Remember, so most common cause of the postpartum pregnancy, it may be due to the inaccurate estimation of the our EDD. So we have to recalculate this one. Okay, so by asking the history of the last menstrual period, and we will apply the Nagel's rule. Okay, we'll apply the Nagel's rule. Okay, so in the Nagel's rule, every one of you know, yes, the how we have to calculate the preterm labor here. Yes, sorry, the how we have to calculate the expected date of the delivery by using the Nagel's rule. That is very simple. So that is very simple. How means like this. Okay, so for the first day of the last menstrual period, we have to add the 9 month plus 7 days. Okay, so this is the how we have to calculate the expected date of the delivery by using the Nagel's rule. Okay, so this one we will reapply and we will recalculate and we will see actually it is the postpartum labor or it is not a postpartum pregnancy. We will recalculate this one. Okay, so the answer goes to the option B as a correct answer. Okay, so what are the problem there may happens in the postpartum pregnancy? Yes, if the pregnancy is going more than 42 weeks, if the pregnancy is going more than 42 weeks, means the baby inside the mother abdomen, it will be a big baby. Okay, so baby may goes to the more than 4 kg, right? So that is what we call as the macrosomic. Okay, so in the macrosomic baby, the all the weight of the baby will be deposited at the trunk and the shoulder. Okay, so all the weight and fat is deposited under the shoulder, so there will be a chance of the shoulder dystocia. Okay, so difficulty to deliver the shoulder. There is chance of the shoulder dystocia. Okay, so along with this, okay, if the macrosomic baby means there is a chance of the a premature rupture of the membrane, but the case is in the postpartum labor, so there is the less chance. But the most importantly, the baby may get enter into the shoulder dystocia. Okay, so along with this, there is in the oligohydramnios. Okay, so if the like pregnancy is crossing more than 42 weeks, means the amniotic fluid will be less than 200 ml. Okay, so here the amount of the amniotic fluid will be less than 200 ml. Okay, so means in the mother abdomen there will be a less space for the fetus. Okay, so in the mother abdomen there is less space for the fetus, means whenever you will palpate the mother abdomen, you will feel complete full of the fetus. Okay, and the amniotic fluid have been low, so the height of the uterus in the postpartum labor is the less than the period of the gestation, because here the amniotic fluid is completely empty. So whenever you will palpate the uterus, you will feel the full of the fetus. Okay, and there is less space for the fetus, means there is highest chance of the cord compression. Okay, so the cord compression is happening, means the fetus will get land into the fetal distress. Okay, there is highest chance of the fetal distress. If the patient is landing into the fetal distress, means this particular fetus will pass the meconium inside the amniotic cavity only, so there will be a chance of the meconium aspiration syndrome. Okay, in the amniotic fluid, the just I will write short form, that is the meconium aspiration syndrome. Highest chance will be there if the fetus is getting land due to the fetal distress due to the less space because of the oligohydramnion. There is the chance of the compression of the amniotic cord, or there is a chance of the compression of the placenta by the fetus. So that is the reason the fetal distress will happen, and the meconium aspiration syndrome also may happens in the our post-term pregnancy. Very, very important. Okay, so another very last problem is the placenta is getting age here. Okay, so placenta is getting the more age here means there is in the placental ischemia. Okay, so due to the placental ischemia and infarction of the placenta, so there is in the uteroplacental insufficiency will happens. Okay, so uteroplacental insufficiency will happens. It means there is in the less blood supply which happens to the, okay, it means the less blood supply which happens to the placenta. Okay, so to the placenta, if less blood supply is happening means the fetus will get the less blood supply. Okay, the fetus will get the less blood supply means there is a chance of the intrauterine fetal death, or there is in the chance of the intrauterine growth restriction also. Okay, so especially there is in the intrauterine fetal death may happens. Okay, so along with that there is in the a chance of the a stillbirth baby. Okay, so there is a chance of the stillbirth also. Yes, the postterm increases the risk of the stillbirth, postterm increases the risk of the intrauterine fetal death, and postterm increases the risk of the meconium aspiration syndrome and the fetal distress, and the postterm increases the risk of the shoulder dystocia. Okay, so these are all the very important problems which will be associated with the postterm labor. Okay, so whenever we will palpate the mother abdomen, okay, remember the mother abdomen is full of the fetus, and we can say that is the height of the uterus in the pregnancy is less than the period of the gestation. Why? Because there is on the less amniotic fluid. Okay, so that is the very, very important thing. Just try to keep in your mind related to the postterm pregnancy. Okay, so here is the again the next question, and the very important question for every one of you, right? Yes, fatapat do response to the question. Which of the following correctly describes the grade 2 molding during the labor? Grade 2 molding during the labor process. Sir, what is the molding, sir? Molding means it is a very simple beta. So consider this one is then the like a birth canal or the vaginal canal. Okay, so from here the fetus head should come out like this. Okay, so if this birth canal is narrow or the fetal head is big, so while coming the fetal head out of the birth canal, that time there is then the compression will be there on the like fetal head. If the fetal head is getting compressed means the skull of the fetus will get overlaps like this. Okay, so or it will get touch, or it will get overlapped like this. So this is what we call as the molding of the fetal head. Okay, so what is the molding of the fetal head? So molding of the fetal head means the overlapping of the fetal skull bones, okay, due to the narrow maternal pelvis, or due to the narrow birth canal, or due to the big head. Okay, so this is what we call as the molding. Molding means overlapping of the fetal head. Okay, so there are the three grades are there in the moldings. So grade 1, grade 2 and grade 3. So what happens in the grade 1? So in the grade 1 just the fetal skulls will touch, just the one skull bone which will touch to the another skull bone. Okay, so there is just in the touching of the bones of the fetal skull. Okay, so that is the grade 1. If the fetal skull bones are touching and overlapping one another one. Okay, so on the one another one bone is the overlapping and it is separating easily. So this is what we call as the grade 2. Okay, so in the grade 3 what happens? The fetal skull bone will overlap and it will not get separate. So this will be what we call as in the grade 3 molding. Okay, so option A, bones are just touching. Okay, so no overlap, just touching. This is what we call as in the grade 1. Okay, so in the grade 2 what happens? Bones are overlapping but can be separated easily. So this will be our grade 2. Okay, in the option C, the bones are overlapping and cannot separate. Okay, this will be our grade 3. This will be our grade 3. Very, very important. Just try to keep in our mind. Okay, so bones just touching, no overlapping. Grade 1, bones are touching, overlapping and separating. That is the grade 2. Bones are touching, overlapping, not separating. That is the grade 3. Okay, so skull bones are widely separated with no contact. So that is the not correct answer. Okay, so for this particular question, the correct answer is the option B. Why? Because they have asked the grade 2. Okay, so grade 2 is the our option B is the correct answer. Okay, hope it is clear to every one of you. The molding of the fetal head, so which indicates the there may be in the cephalopelvic disproportion, or there may be in the narrow or birth canal of the mother. Okay, so very important. The next question of the discussion is this one. Which of the following statement is true about the Caput succedanum? So what is the correct answer? Which of the following statement is true about the Caput succedanum? Option A, it is the correction of the blood beneath the periosteum and limited to the suture lines. Option B, it is the soft tissue swelling that crosses the suture line. Option C, it is always associated with the skull fracture. And option D, it appears several days after the birth. So what is the correct or the true statement about the Caput succedanum? So what is the true statement about the Caput succedanum? Yes, I want your answer in the comment box. So please do mention your answer in the comment box. Which of the following statement is true about the Caput succedanum? Yes. Very nice of you all. Okay, many of you have given the correct answer. That is the option B. So it is a soft tissue swelling that crosses the suture line very easily. So this will be a very important definition of the Caput succedanum. So in the Caput succedanum, beta, so there will be accumulation of the fluid will be there. Okay, so there will be accumulation of the fluid will be there. So that is beneath the scalp and above the periosteum. So it is not beneath the periosteum. Beta. So option A is telling the collection of the blood. Okay, the blood is collecting and which is connecting below the periosteum and which is limited by the suture line. So this is the standard definition of the cephalohematoma. Okay, this is the standard definition of the cephalohematoma. Sir, we are not getting complete clarity about the cephalohematoma and the Caput succedanum. Please make it clear, sir. Yes, so understand by this particular diagram, it will be very much helpful to every one of you. So remember, this will be a brain. Okay, so on the brain, every one of you know that we have the skull bones. Okay, so this skull bone, this is the our skull bone, right? So this skull bone, outermost layer, what we call as the periosteum. Okay, so the outermost layer of this skull bone is the periosteum. So on this periosteum, so we have the layer of the skin, we call of the layer of the skin of the our head is the scalp. Okay, so this will be a scalp, this will be a periosteum, and this will be a brain. Okay, so here we have the meningeal layers also. Okay, so meningeal layers also we have here 3. So that is not going to be a very important here. So just remember, so here we have the skull means, so skull, in between the two skull there are the like joint, we call the joint between the skull bones, that is on the sutures. Okay, so these are the suture lines are there in the skulls. Okay, there are the suture lines which are available in the skull bone, right? So there is no any suture lines for the scalp. Okay, there is no any suture line in the scalp. Okay, so in the very important case of the like Caput succedanum, there is in the accumulation of the fluid which is below the scalp and above the periosteum. Okay, so this is above the periosteum and below the scalp, and here there is no any suture line, so it will easily cross the suture line. Okay, so because the suture line is present in the periosteum. Okay, so below the periosteum or in the suture, like in the skull bones, not in the scalp. Okay, so this is the diffuse swelling of or the accumulation of the fluid, okay, which is below the soft tissue or the below the what we can say the scalp line and above the periosteum. So this is accumulation of the fluid. So we call this one as in the very important accumulation of the fluid. Okay, so this is the case of the Caput succedanum, right? Similarly, so understand the concept here. So this is the brain. Okay, and on the brain we have the skull bone. We call this one as in the skull bone. Okay, so the outermost layer of the skull bone is the periosteum. Similar concept again. Okay, so and above this one we have the scalp. Okay, so above this one we have the scalp here, right? So here we have the meningeal layers, right? So here we have the suture lines of the our skull bones, right? So if in case the blood is accumulating beneath the periosteum. Okay, so this particular concept, what we call this one as in the a cephalohematoma. Okay, so hema means a Yes, the hemorrhage. Hema means the blood. Okay. So here the blood is accumulating below the periosteum, and which is here the suture lines are there. Okay. So below the periosteum means here we have the suture lines. So it is unable to cross the suture line. Okay. So this is what we call as in the case of the our cephalohematoma. Okay. So this is the case of the cephalohematoma. Very, very important for your exam. Yes, the cephalohematoma will not crosses the suture line, and the Caput succedaneum will crosses the suture line. Very, very important. Okay. So here the question is there. Okay. So option A, which is the collection of the blood beneath the periosteum and limited to the suture line. Limited means it is not crossing the suture line. So this will be a classical definition of the our very, very important cephalohematoma, right? So, but they have asked the question related to Caput succedaneum. So it is in the swelling which crosses the suture line is the our like Caput succedaneum. Hope the concept is very much clear. And option C, it is always associated with the skull fracture. Beta, the cephalohematoma is associated with the skull fracture, not the Caput succedaneum. Okay. So Caput succedaneum, which happens due to the a constant pressure on the particular part of the fetal head while the vaginal delivery. Okay. So during the vaginal delivery, on the presenting part, there is a constant pressure is there due to the uterine contraction and due to the pushing effect by the mother. So there is a constant pressure on the part of the fetal skull. So that is makes the accumulation of the fluid in the particular area. Okay. So that is the Caput succedaneum. So it is not associated with the skull fracture. Okay. So then the option D, it appears several days after the birth. Beta. So Caput succedaneum will be comes by birth and it will dissolve within a few hours after the birth. But the cephalohematoma, it is not present by birth. So after the birth, after the few hours after the birth, it will be visible. Okay. So cephalohematoma will not present by birth, and the Caput succedaneum is present by birth. Okay. So immediately after baby coming out of the birth canal, we can see the Caput succedaneum. But a cephalohematoma, after immediately coming the baby out of the vaginal canal, we can't see the cephalohematoma because the cephalohematoma happens few hours after the birth, and the Caput succedaneum is happens by the birth. Okay. So while labor process only the Caput succedaneum will happens. Okay. So this is the golden difference between the cephalohematoma and the Caput succedaneum. So this will be very, very important for your upcoming exam. So try to remember and understand almost all point we have discussed now. So just I am brushing your difference between the cephalohematoma and Caput succedaneum. Okay. So what happens in the Caput succedaneum? In the Caput succedaneum, there is accumulation of the fluid is there. In the cephalohematoma, there is accumulation of the blood is there. Okay. So Caput cephalohematoma, there is which happening below the periosteum. Okay. So below the periosteum means there is suture lines are there. So it does not crosses the suture line. Right. Similarly, the Caput succedaneum, which happens above the periosteum below the scalp line. Okay. So which will easily crosses the suture lines. Okay. So Caput succedaneum, I told immediately after coming out of the birth canal, we can see the Caput succedaneum. Okay. So timing of the appearance present at the birth. But so cephalohematoma, which appears hours to days after the birth. Okay. So immediately it is not visible. It will be visible after few hours or after 1 day or the 2 day after the birth. Okay. So that is the Caput cephalohematoma. Okay. So this Caput succedaneum is the generalized one. Okay. So this will happens like if I am pushing like this means the swelling will come this side. I am pushing like this means the swelling will come this side because it is crossing the suture line and which is generalized one. But the cephalohematoma is the localized swelling is there. Okay. Only one area. So it will not go from here to here and here to here. Okay. So the localized area and which will not fluctuates. Okay. So cephalohematoma, it will not move from one area to another area. Okay. So that is the whenever we will push, that time it may fluctuate, but it will not cross the suture line. Okay. Remember the very, very important one. Okay. So consistency. This the Caput succedaneum is the pitting one. Okay. So when I will push like this, there will be a depression will form like this. Okay. So but the cephalohematoma is the non-pitting one. Okay. It's the firm fluctuating. Okay. And the non-pitting, right? It is the non-pitting. Remember. So then the causes, I told a constant continuous pressure on the a particular presenting part by the vaginal walls or by the contractions of the uterus. So that causes the Caput succedaneum. Okay. In the cephalohematoma, which happens due to the rupture of the blood vessels at the head of the brain. Okay, so head of the baby due to the like fracture of the skull or anything, or the due to the false like faulty application of the our instruments during the delivery. Okay, so that is a very important. Okay, resolution I told this caput succeedum, it will visible by the birth and it will resolve within few days or within few hours. Okay, so within one day or within few hours only it will get results. Okay, so the cephalohematoma, it takes weeks to months to get resolved. Okay, so this is a very important one. And complication, usually there is no any complication for the cephalohematoma, and in the like in the caput succeedum there is no any complication, but in the cephalohematoma it may causes the jaundice. How, sir? How means here what is accumulating in the cephalohematoma? The blood is accumulating. Blood is accumulating means the red blood cell will get break. Okay, so red blood cell will get break means yes, there is in the release of the bilirubin will be there. So bilirubin will be increased here, so that it may be associated with the hyperbilirubinemia. Okay, so and it may be associated with the fracture of the skull. Okay, and very important. Remember, so may causes the jaundice due to the blood breakdown. Okay, so this is the very important thing. Just try to keep in your mind, right? So hope the concept of the cephalohematoma and the Caput succeedum is very much clear to every one of you, right? So these are the very important questions and concept what we have discussed in the today's session, and these are the your assignment of the these are your assignment. Okay, so fluid accumulation in the brain. Question number 1, the fluid accumulation not in the brain, fluid accumulation at head of baby and which crosses the placenta, which crosses the suture line. What you call this one? Okay, this is the question number 1, and the question number 2 is blood accumulation below the periosteum and it will not crosses the placenta, it will not crosses the, then again the word placenta, it is not crosses the suture line. Okay, so what is the answer for this one? Okay, so these are the very important 2 questions what I am giving to assignment. Okay, so at the end of the class, so every one of you, so please do mention the comment for these 2 questions, so I can come to know that whether the concept what I am explaining is understandable to every one of you or not. Okay, so hope that today's session is you people enjoyed, right? So here is the again a small information to every one of you, and while are preparing for the Norcet 9. Okay, if you are searching for the good test series, here at the Super 60 test series, we are giving this one as a live test series from the 6 a.m. to the 11 p.m. and at the daily 11:30 p.m. you people will get the very important all India ranks. Okay, so along with this one, every question is having the clear rationale which includes the complete nursing and non-nursing portions, and we are giving this one as a real-time exam practice. Okay, so that is the for the 18 minutes 20 MCQ, total 5 sections. Okay, total 5 sections we are giving. Okay, as like your real exam, so it will reduce your all the confusions, it will reduce your all the conflicts, and it will improve your confidence. Okay, so very important. If you want to become a part of this one, yes, do download the Master Nursing Classes app. I have given the description link in the description box, and if for the daily updates and the daily golden point revision and the daily flashcard study, so you can join our WhatsApp channel. I have given the link in the description box. For the daily quiz, join our most important Telegram group. I have given the link in the description box. Okay, so thank you so much for the watching the video. Okay, so till the end, and best wishes for your preparation. Keep preparing, work hard. Okay, so today my energy was somewhat low because I'm experiencing some little bit issue with the throat. Okay, so again with the tomorrow's video I will come with a full energy, and I will blast the particular session in the tomorrow session. So please do join the tomorrow session also at the same time 6 p.m. don't forget. Okay, so thank you so much for the watching the video till the end, and good luck, all the best, keep preparing. Bye bye, take care. Thank you every one of you.